Hi, everyone. I'm Lara Briden. I'm the author of a couple of books, Peri Repair Manual and Hormone Repair Manual. But today, I'm actually here to be the interviewer. I'm going to talk to Dr. Nikki Kay about her book, Hormones, Health, and Human Potential. And so I've got Nikki here with me. Actually, Nikki, tell us a little bit about yourself and the book.
Listen, I'm so excited to be speaking with you, Laura, in person, as it were, virtually, because I'm a great follower of your work. And the reason I wrote this book, Hormones, Health and Human Potential, is because I am passionate about hormones. And the reason I am passionate about them is because they're really complicated, especially female hormones. But I love complicated. I love unpicking the details and finding out, understanding what's going on, but not just an academic challenge, of course, but then applying that and helping women or supporting them in them helping to decipher what's going on and giving them the best advice and recommendations so they can get the most out of their life and reach their full potential. So yeah, I've been working in hormones. I'm quite old, so I think it's at least 30 years. Yes, it is. Clinically seeing people, but also in terms of research as well. So that's me.
I love that you're a clinician and a researcher and a dancer, of course, when this is you on the cover.
Oh yes, that was the other sort of theme about the whole thing. When I this is a long time ago, decided to study medicine, I have to admit it was partially a personal motivation, because I was dancing and doing a lot of sport, and I wanted to know, how can I be the best dancer I can be? And I realized that actually, number one, I needed to really understand a lot about the body. And then I realized that actually hormones were the key. So You're right, that's how I've written the book in my sort of slightly ballet artistic thing. That's yes. Why there are acts and scenes and not parts and chapters, right?
I love it.
And that's the picture of me when I was just spontaneously doing a jump on the beach in Australia, actually, as it happens.
I love it.
And I just thought, well, actually, that's, not a bad image to symbolize or represent the energy and vitality we can get from our hormones.
Entirely. And we're not alone today. We have Tanya with us. We're together today because we're also going to be together in real life in a few months in the UK. So Tanya, do you want to tell us a bit about you and our upcoming event?
Yeah, so thank you, ladies, and it is just such a joy to be collaborating and working with my two heroines of anything to do with hormones. So yes, I'm going to be hosting an amazing event with these two wonderful women in September, which we will tell you more about later on. But I'm a functional medicine practitioner specializing in women's health and hormones, and I'm thrilled to be here collaborating with these two wonderful brains. So over to you, Lara, because this is going to be a fascinating interview. Thank you.
Yeah, so our event in September is going to be a deep dive into the menstrual cycle, and we're going to hear about what Dr. Nikki calls the women's hormonal odyssey. I love that. I love you're a writer, obviously. I love the words you use. But today, to not steal our thunder from September, we're actually going to be looking at something a little different and something that I'm quite interested in. We're going to be looking at the intersection between underfueling, call it energy deficiency, and perimenopause. So women athletes, even amateur athletes in their 40s who are experiencing menstrual disturbances and are really not sure what's going on. Is it that they're underfueling? Is it that perimenopause coming in? So, and we'll talk. And so, yeah, Dr. Kay, tell us a bit more about that and sort of your method of using, serum hormone levels and blood testing, sort of in a zoomed out way, looking at the whole context of the menstrual cycle and the woman. Is that right?
Yeah. So the challenge, by the way, not just for individual women, but for me as well.
Yeah.
By the way, both as a woman having gone through that and also as, a clinician, a doctor trying to help women do the detective work, I suppose we would say. Do the detective work so they can navigate through this way, because what we're talking about here is the perimenopause, I think most people are hopefully familiar. This is the transition from having regular menstrual cycles, hopefully, and then the destination. It's the graduation to menopause, and that is Tanya's expression, but I love it. The graduation to menopause, it doesn't happen overnight. It doesn't, one day you have regular cycles, the next day you wake up and you're menopausal. It doesn't happen like that. It is a journey. So absolutely you have to navigate your way. And during that time, the hormones getting a bit confused, by the way. They normally have this beautiful synchronized choreography of the menstrual cycle. But in this transition phase, it is a little bit stop and go and things get out of sync. So the woman you can present and what you experience is, number one, of course, irregular periods themselves and typically shorter cycle lengths, maybe because you're not ovulating, and different levels of hormones. Basically, yes, it gets a little bit chaotic, shall we say. But this is not dissimilar to the situation we see in women who are exercising. And I totally agree with you, Lara, that we're not talking elite athletes. I'm not an elite athlete, but I like to think that I am. I exercise in a serious manner, in a regular fashion, not just with my ballet, but for example, today I went swimming and whatever. So anyway, sometimes you can miscalculate the energy you need to cover all these different activities you're doing. And this leads to a situation of low energy availability, as you mentioned. And this is a problem, especially for the hormones in the body that need energy to keep the beautiful choreography going, especially of the menstrual cycle. So you can end up in this situation of having symptoms, feeling tired, just not feeling great, having irregular cycles. And it could, if you're in your 40s and you're doing a lot of exercise, it is actually, if I just give you that amount of information, on the surface of it, it could seem difficult to distinguish between, is this perimenopause or is this, a mismatch of the energy intake and energy demand? So that's really what we're talking about. That's why on the surface, it seems quite tricky. But so what you have to do, I mentioned hormones are complex, you have to go deeper into it. Well, first of all, just going through, my approach would be, let's go through in detail what the individual's doing. So it's like, take me through a typical today, and what are you eating, what exercise you're doing, and it might already become obvious that actually it sounds very much like maybe she is underfueling. For example, skipping breakfast, doing fasted training. Actually, then that would lean me already slightly more that way. Whereas on the other hand, if the nutrition and the exercise sound pretty reasonable, balanced in that sense, then actually I might already be tending more to think this is perimenopause. So that's the first step, just get the information.
Clinical. Yeah.
The next one, the story. The next step is, now let's look at the hormones and see what clues we get from those. And especially for the energy availability, actually using thyroid hormones, specifically the T3. The T3 is the easy way of doing a diary and energy expenditure calculation.
I love that.
Which I mean, that kind of fills me with horror. I have done it in the past in research studies, but that's before we realized, or I realized that, in general terms, we realized that T3, and it's now published, that is official, as it were, that this is a very good indicator of its energy availability. So the first thing, actually really useful, look at the thyroid hormones, the T3, is the energy more or less okay or not? And then we can go on from there and look at the female hormones. And we were discussing beforehand that typically doing a blood test on day 3 of the menstrual cycle, so the start of your menstrual period is that's day 1, and so 3 days later, that's the typical time when people are told to do a blood test for female hormones, unless you've got something really like obvious, like you have reached menopause, but you'll know about that because you haven't had any period for 12 months, by the way. So it's kind of, why would you do that? Sometimes even that might not be that helpful. We might not get the full information. So again, it's a case of detective work and getting the most information you can, maybe doing a blood test at a different time of the cycle. in the time when you would expect progesterone to be higher, for example, in the luteal phase after ovulation. If ovulation hasn't happened, obviously it's going to be lower. And there are other bits and pieces that one could also ask if the woman maybe is tracking her basal body temperature and other things like this. So it is pieces of a jigsaw puzzle, pulling these all together to help distinguish between these two situations, because it will be slightly different which way you go, depending on what you think is the most likely reason what's going on here for the woman.
That's great. And you're so right. You can't just take one day, one set of female hormone readings and really conclude much from that. It does require that putting everything in context. I have a question, because one of the things for younger women, and I know of course today we're talking about women in their 40s, but for the underfueling or the energy deficiency, I tend to look for low LH. That would be a day 2 or 3 reading, but like quite a low LH compared to FSH. And for younger women, you can sometimes I see LH down at like 1 or less than 1 or 2.
Oh, less than 1, I say, yes.
Yeah,
so for sure, we don't want to dismiss doing the blood test on day 3. I think it's not unreasonable. But to note that it's the subtleties of it, because this is the other thing that I find happens, is that a woman, say, well, actually of any age, frankly, a woman says, well, I've had this blood test on day 3 and I've been told that there's nothing wrong with me because these hormones are in the range.
Exactly.
But she adds, but I haven't had any period for 6 months. I don't care what the hormones are, but not having a period for 6 months, and you are, well, let's say for argument's sake, in your 20s or 30s, and you're not pregnant, by the way, that's definitely, whatever the blood tests say, there's something going on. And it's exactly, I agree with you, it's the subtleties. It might be in the range, but if it's scraping along 1 or less than 1, in that clinical context of the woman not having periods, definitely that's a big warning sign. And I agree with you that LH is actually the more sensitive one. And that actually is the definition that we're told from the WHO to distinguish if a woman's not having periods, what do? You look at the LH, right? If it is low range, you next look at the prolactin. Right. Oh, by the way, she's not pregnant. Okay, so I'll give you that free.
That's
all right.
given,
Okay, all right. We're done pregnant. Not pregnant.
Yeah.
So not having periods. So you look at the LH, and then if the prolactin is in the normal range, now we're saying, okay, we know there's something wrong with the central control system. It's switched off. By the way, the reason what's prolactin, the reason I'm throwing that in there is because this hormone, well, to be actually honest with you, it comes to the fore if you're breastfeeding, and it goes really high. That's the main purpose of it. But sometimes the body gets it a little bit wrong and it produces too much, and that can turn down the LH. That's why breastfeeding women, by the way, don't often have periods. So, but you're right about this is a long-winded way of saying, that I agree with you, and that actually looking at where the LH is the really sensitive one. And if it is low range, you can pretty much say this is probably more, and the prolactin's normal. We're dealing definitely more with a low energy availability symptom on the backdrop of the woman saying her periods have stopped or irregular periods. That's the crucial thing. That I love my blood test, by the way, and I want to know what those numbers are. But before I look at the numbers, I need to know all the story about the woman, you see, because if you just look at those numbers, I agree. You might just say, well, that woman must be fine. It's in the range. But you have to put it in the context of what the woman is telling you about her periods.
And so I talk about LH a lot, and sort of using that to try to differentiate between energy deficiency and PCOS, or polycystic ovary syndrome. Yeah,
exactly.
Another whole other topic, which we won't get too far into today. But then people always ask me, well, what should LH be? Like, what's the optimal range? But this is the thing to understand, is that both FSH and LH, those two pituitary hormones, do trend upwards into our 40s. They're both going up. But this is where you have to be able to essentially look at the ratio, or try to, as you say, try to see a pattern. I love, just as a takeaway for everyone listening, what Dr. Kay said before about low T3 can be an indication of underfueling. So can low LH compared to FSH, whereas PCOS would be the reverse often. There'd be a high LH.
T3 would be fine, and LH tends to be higher than FSH, you're right. And if it's more the perimenopause, in other words, now the ovaries are sort of slowing down, going into retirement, then actually there's another pattern here. The FSH will be a bit higher, right, than you might expect. So, but these things might still be in range. So that's the crucial thing. And this is the bit, putting the bits of the jigsaw together. You can't look at just one hormone in isolation and make a conclusion for that. I mean, that's not right. Number one, you need to know all the clinical context of the individual, but also the details. What's the relationship with LH? What's FSH doing as well? I also want to know what estrogen's doing. Make sure the prolactin's all right. What's the testosterone if it's thinking PCOS? Oh, by the way, what's the T3? So these hormones, that's how they work in the body. The hormones work in teams as a network. So obviously we should look at them in that way, the way they work in the body, not in isolation. And looking at, I mean, I know we're talking about women, but men, it's like they just want to know what testosterone is. And I say, and it's like, why do you just, it's like, and they want to know this number. It's like, yes, but that tells me nothing. I need to know what the team is doing of the hormones. What's LH, what's FSH? So the same thing. You have to look at the whole picture to put it all together to make sense. It's obvious, right? In my book, I describe the endocrine orchestra. So the conductor of the orchestra is the pituitary gland, like you mentioned, the controller. And then all the instruments are the different families of hormones, like the strings. We can make them the reproductive axis, for example. I don't know. You see, in all these things. And so you wouldn't just look at the score of one individual instrument, would you? If you're looking at a symphony, if I said that to you, it's like, well, no, of course you wouldn't do that. You know, you want to see all the other parts. And it's the same thing for the hormones, you see. You want to look at as many as you can and get the whole complete picture.
That's a beautiful analogy with the orchestra. And just to say to everyone, Dr. Nikki's book is also about men. It's not just women, so that's good. It's good. We're not talking too much about men's hormones today because I know very little about the male side of things. But can we talk just a little bit more about estrogen in the context of perimenopause? Because before we started recording, we were talking offline a little bit about how actually estrogen, there's this idea that it goes low in perimenopause, but it can actually paradoxically go quite high. Progesterone tends to go low. That's a key feature of the anovulatory cycles that start to happen. But you do get this kind of untethering of estrogen. You can potentially see it on day 3 again. You can see it later in the cycle. Do you see that in your research or with your patients?
Yeah, absolutely. So, you know, perimenopause, it's like Vivaldi and the Four Seasons in terms of hormones. Anything goes, sort of thing, up and down. But the general trend, once the woman, the destination of perimenopause, that graduation to menopause, Tanya, you know, I've using that term now. I love it. Graduation to menopause. Anyway, so this is Tanya. So I'm just saying, that journey, the ultimate destination is absolutely all the ovarian hormones will be low, both estrogen and progesterone. But it's the journey there because of this sort of basically the conductor's gone a little bit haywire, or more to the point, the instruments have gone a little bit haywire. The ovaries have just got out of sync and not sure are they coming or going. And this can be reflected in the actually higher estradiol at temporarily. At the ending point, of course, it will be low, we know. And some women, it might be a sort of a slope like that. But for many women, and I saw one just the other day that we were discussing where actually I was quite surprised. It's wow, day 3, you would expect that estradiol to be low because not much is happening yet. And yet hers was actually quite, and yet she was in her 40s, and yet actually it was pretty high. But I think you made a very good point, Lara, earlier, that, you know, the pituitary gland gets a little bit cross with the ovaries. So increases the production of FSH, follicle stimulating hormone, the clues in the name. It's like, come on, ovaries, what are you doing? You're slacking. And so the ovaries are like, oh, all right, fine, we'll make an effort. And this is in the early bit of the cycle. So actually, that's why the estradiol doesn't seem sort of the right pattern. It can actually be high, but this would also account for why lots of perimenopausal women, apart from the shortening of the cycle because they're not ovulating, also often have very heavy periods.
Yes.
Okay. And that's because of the high estrogen. And I experienced this myself. Now I think back, I was like, I remember that time we're on a ski slope. It's like, oh, not now, please. Anyway, you know, because actually as you say, the estradiol is untethered. And so that would explain why you often get very heavy bleeding in the perimenopause and sometimes really long bleeding. And actually the solution there is to add in progesterone to sort of balance up the estrogen, because apart from anything, it's just like really inconvenient and just really tiring to have a period that lasts 10 days.
Yeah, and potentially by progesterone, if people can access it, we do mean like the body identical, like in the UK and New Zealand, it's called, the brand is Utrogestan.
Exactly.
In other countries, it's Prometrium. It can be, and Professor Geraldine Pryor, who will just mention, is a strong advocate for, at times, the use of progesterone only during perimenopause to control both heavy bleeding and sometimes to help with some of the neurological symptoms, because that's the other reason for the crazy heavy bleeding of perimenopause potentially, is that losing progesterone. And this is another place of overlap, because with underfueling and the relative energy deficiency in sport, and I've talked to a number of researchers about it, I'm curious to hear your view. Like, there had been this idea, well, you lose your period, but there's, as we've talked about, there's a subclinical anovulatory disturbance that happens before losing your period, depending on the severity. It might not be that you lose your period. Some athletes can have actually heavier than normal flow, arguably. I mean, I'd love to hear your view. And that could be because their ovulation is not as robust, not as strong because of the underfueling. They're missing progesterone. So you paradoxically get this heavier period. Is that something you've seen?
Yes, absolutely.
Yep.
And I think it's a bit like, you know, like we talked about perimenopause as a transition from having regular cycles, regular periods, to menopause, the full stop. And we said already, it's not an on-off switch overnight thing. And the same for if you're underfueling. It's not suddenly one day you've got regular cycles and then suddenly your periods, you wake up and your periods have stopped, because the body will struggle along. The body will go through this, like this spectrum, subclinical spectrum. So it will try and save energy. And one way of saving energy, if you're having a menstrual cycle, is stop the ovulation bit. Because if you stop the ovulation and therefore the production of progesterone, that saves energy, because progesterone, remember, increases the metabolic rate. So you need extra energy during the luteal phase. So step one, if you're the body, if you're like the engineer, how am I going to save energy? The first step is, let's switch off ovulation, because that will save energy, and maybe that will do the trick. So that's why the cycles can become a bit shorter, but estrogen might still be produced. So like you said, the woman might still say, that's why it's called subclinical. She won't realize it, because if you ask the woman, she'll say, yeah, I'm having regular periods. And so you might on the surface think, well, there's nothing wrong. But if you dig a little bit further, it might be this subclinical thing and ovulation. And then gradually, if you continue with that energy deficit, then the body's going to have to go even more severely into eco mode. It's like, well, we tried switching off the ovulation, keeping the progesterone low, but actually now we're in such, you know, energy deficit that we're going to have to switch off the whole apparatus, and that is where the periods stop. But I'm very familiar, and I've spoken to the amazing Professor Geraldine Pryor. She's done so much excellent work in this, and that this is really, what best thing would be if we could pick up women in this transition phase, these subclinical phases, because what we could do, number one, if it's an energy deficiency, let's address that quickly before the periods totally switch off and the estrogen as well goes low, and also potentially add in the progesterone there. But also the same applies, it's the same sort of thing, like you said, with perimenopause. The perimenopausal woman who isn't ovulating but the estrogen is quite high, then actually what she really needs is the progesterone. And you're right, the body identical micronized progesterone, whatever brand name we're going to give it, Utrogestan, Prometrium, whatever, that ideally is, of course, it just kind of makes common sense. You want to put into your body what you normally produce. Although, to be honest, in perimenopause, sometimes I've seen women who literally are bleeding all the time. Then actually, even, you know, the trusty Utrogestan, you might need something with a little bit more oomph. And sometimes, you know, the Mirena coil with norethistro, because at least it's produced continuously there. So it will depend on the woman. But I think we put so much emphasis on estrogen. Everyone's heard of estrogen, estradiol, the most active form of estrogen, but sometimes it takes the limelight, but sometimes we should emphasize that progesterone is also a really important hormone, especially, like you said, for the mental, for the brain. And also it helps sleep, by the way, which is another reason why HRT often helps with your sleep.
It's pretty popular, that Eutrogestin at bedtime.
Oh,
is
lovely.
a sleeping pill for some women.
It is
So,
a natural sleeping pill.
yeah, and actually, I'll just chime in. I agree that the Mirena coil or IUD can be helpful during the crazy heavy period time of perimenopause, so for what it's worth. And it doesn't suppress ovulation, or it doesn't,
No.
depending on
We
the
don't
woman
know.
and kind of later, especially because the dose of the levonorgestrel will be stronger in the first year of insertion,
exactly.
but then it tends to often women, especially women in their 40s, can ovulate through that. One thing, so I'm just going to clarify for everyone listening. So we talked about anovulation, which is a cycle. It's not even a cycle really, but like a period, bleed where ovulation did not happen. That's anovulation. But part of the subclinical ovulatory disturbance that you've been talking about, and Geraldine Pryor talks about, is you might still ovulate, but you have a shorter luteal phase or a less robust progesterone. And you can, Geraldine uses a quantified temperature tracking method. So you may have spoken about that with her when you met with her. But yeah, that's a way to try to get to quantify the size essentially of the luteal phase. Is progesterone high enough? Is it long enough?
Yes, I think you're right there, because this is a case where actually, as I said, I love hormone tests and everything. Yeah. And actually, but this is a situation where the measuring your temperature, the basal body temperature, as it's called, because we just mentioned that if you produce a decent level of progesterone during the luteal phase, if you've ovulated and it's a full-blown sort of all the orchestra working, then it will raise your metabolic rate, and that's why your temperature will go up for at least 3 days, not just a little, maybe it went up, it will go up and sort of stay up for a sustained time. But that is much better, or even longer, but certainly you've seen it goes up and it stays up, but it doesn't just sort of quickly go up and then come down. That's probably a little bit, but actually that is very, very good for getting an assessment of like the average production of progesterone over that time, because the production of the hormones, we just published a paper on this, is actually very volatile. Even in a woman who's ovulating and producing a decent progesterone, if you measure it day by day, it's not the smooth curve, by the way, you see in the textbooks, okay? Because hormones, guess what? They go up and down like this. So if you do a blood test, you might catch it on a bad day or a good day. So you might get a false sense of security. So I absolutely agree with you that the temperature method is, number one, it's not invasive, but also gives you a more reliable way of, on average, how's the progesterone doing. And in fact, we're going to use that after speaking with Geraldine and looking at all the evidence. I'm using that now in the study I'm doing with dancers. Because number one, it's easy for them. They just stick the thermometer in every day, no problem. And it's very simple, straightforward, not expensive, and actually it gives them, and also then they are involved in it. So they record it and then they can get the patterns themselves. But this low progesterone, this subclinical thing, actually is very important for health, because again, Geraldine's great research work shows that the low progesterone, we always talk about estrogen, but actually low progesterone, as you know, can be not so great for bone health, cardiovascular health, all those things. So, progesterone, we're flying the flag for progesterone. We should give it its worth. And also we think that sometimes women who have, problems conceiving or recurrent miscarriages, in some cases, that is because there isn't sufficient progesterone. Because, by the way, the word progesterone, we break it down, it means pro-gestation, gestation being pregnancy. So it supports pregnancy. So no surprise if it's low, that could be a problem in fertility and sustaining pregnancy. And some gynecologists actually, if we know the woman tends to have this lower level of progesterone, they actually give her progesterone to maintain that early pregnancy, to prevent miscarriage. So yes, definitely paying attention to progesterone for all these reasons is very, very important.
It's great. Of course, we're going to talk more about wonderful progesterone and estradiol in September when we're in person. I'm so looking forward to it. It's just going to be, yes, sort of a subtle and sort of more nuanced conversation about the benefits of a ovulatory cycle, as you've said, not just for making a baby if you want a baby, but also for general health, because both estradiol and progesterone are so good for general health. But before we leave the topic of, before we kind of sign off, I wanted to ask you a bit more, because there's a patient story or a case that kind of prompted my questions for you today. Isadora, I think it's her name's Isadora, and
as in Isadora Duncan, I was thinking of a dancer, that's why.
Lovely. She's in scene 6, where you two talk about what you call the hormone supermodeling, or like the, this, what you've been describing today, like using multiple blood tests kind of slotted into context and trying to interpret them. So you provide Isadora's case there, and people can look at that. But one thing I noted, you do talk about, you use the phrase low carbohydrate availability. So I'm curious, because I clinically have observed that some women, not all women, are very sensitive to carbohydrate intake specifically, not just energy intake. And I've had debates with people over the years, and people saying, oh, it's just energy. What's your assessment? Do you feel like at least some women have a responsiveness, not just to energy, but to carbohydrate specifically?
And definitely, and there is research to back this up.
Okay.
Another great female researcher, Anna Lukes. I think she's actually Canadian, is she not? Anyway, or is she American? You'll claim her for Canada.
She's American, but I've
her
papers.
But
tell us more, because I'd love to hear kind of your take on carbohydrate.
Well, at its sort of basic level, energy availability. Energy could come from any food source, right?
Yes.
Just simple maths, calories, etc. But actually, as it turns out, for female hormones, love carbohydrate. Did you know? Complex carbohydrates, so bread, pasta, all those things that actually some women actively avoid, especially some of the athletes and dancers I work with, for some reason have it in their minds that these are evil, and you just look at a piece of bread and you balloon. But actually, there is definitely hard research facts from Anna Lukes and also from Louise Burke in Australia. Has done a lot of work on this energy availability. Actually, if we want to be more precise about it, we should say carbohydrate availability when all said and done. So that is definitely important for female hormone health. And lots of people say, oh, but surely these female hormones, especially estrogen and progesterone, we're talking about, they're steroid hormones. You need a lot of cholesterol. You need to eat good fats. Of course, you need to eat some of those, but there's no point giving all the building blocks if you haven't got the energy, you haven't got the conveyor belt, the thing working, the orchestra playing, to put those into action. So I think definitely people have not realized the importance of carbohydrate. So that's why I prefer carbohydrate availability from research, but also just from clinical practice. Typically, those are these women, these athletes, these exercisers are the ones that I ask them what they eat during a day, and there's hardly any carbohydrate, and certainly not carbohydrate around exercise, which is crucial because you need carbohydrate for high intensity exercise. So you see they're on a double problem. Then they're not eating much carbohydrate at all, and they're using any carbohydrate they're just scrounging what they have for their exercise. And so definitely they're low, and therefore no surprise the female hormones won't like that, and their LH will definitely be lower range, and so will their T3. T3 is very sensitive, guess what? Carbohydrate. So that's my view. That's my view, definitely. Carbohydrate availability, we need to talk more about that.
Absolutely. And I'll just clarify, because I know there's going to be some people listening who are like, oh, but wait, but I do well on a lower carb diet. So I just want to say, I mean, again, it's all about context, which is the point you've been making. We are talking about very active women who are underfueling generally, and potentially underfueling with carbohydrates specifically. But that's not to say, I mean, there are also women who have insulin resistance or even type 2 diabetes, or in a different situation. And I think, I don't know what you think, but I feel like for some women, context dependent, an intervention, even temporarily, of a lower carbohydrate diet can be beneficial for them. But that doesn't mean that that's what everyone needs to be doing.
Exactly. So I think as you say, to put that in context, there is an obesity epidemic. sadly. And also more my years working in the NHS, which was in a type 2, well, a diabetic clinic, type 2 diabetic coming in. And if the woman, frankly, was overweight, not exercising, then actually I will be saying the opposite to her. I would be saying, actually, yes, we've got to not like diet, that word diet, I hate it. We've just got to be careful with the carbohydrate portions and the type of carbohydrate. We've got to give the slow release, the brown bread, all these things, not the fast acting ones, which, you know, anyway, so we don't want to be doing that.
And that's a different
topic. So that's a different person, but you're absolutely right. People, if they're confused listening to this, you know, you've got to, it's for the individual. So if you do need to be careful about your intake of carbohydrate because you've got insulin resistance, maybe type 2 diabetes, maybe you have got PCOS, the full-blown syndrome, absolutely, that's that. But if you are somebody doing a lot of exercise, then that is a different situation. So context is everything.
Context. And I think there's a genetic component too with the carbohydrate sensitivity or the which is, and I have this great forgotten the details of it, but it's sort of like a bit of information suggesting there's going to be a ancestry component. So I think those of us who maybe descended from agrarian, you know, people who were eating a lot of grains and carbohydrate, it's like our whole HPO axis, that's the, you know, communication between the brain and the ovaries, is calibrated to a higher carbohydrate intake. Whereas maybe for other people with a different ancestry, they're not going to be as sensitive. So I mean, so that there's lots of nuance around it. And
well, definitely there's a genetic component. They think, for example, with PCOS, even you see, and it was actually quite helpful, maybe in days of, you know, when there wasn't much food to go around. Yeah, exactly. The thrifty genotype, so it was a good idea.
Yeah.
And also there's the epigenetic effect. If you were a baby born during the Second World War in times of, frankly, starvation almost, then you're going to have the thrifty just temporarily, but then it's a tag that's passed on to generations. So not only is the context for the individual, but yes, context for the person's, you know, lineage and all that sort of thing, other things that have gone before even. So there are so many nuances to it. And so, you know, we don't want to make too many generalizations, which I think is the problem that's happened, you know, don't you think? That people just pick up on a story. It's right. Ketogenic diet is right for everybody. But if you think about that for a second, that can't possibly be right because we're all individuals and all different.
Exactly. What works for a 45-year-old man is not necessarily going to work for a 19-year-old girl who's over exercising and trying to get her period going. I mean, just to really zoom out. It's so well said. Yeah. Great. Is there anything else? Tanya, do you have any questions? You've been able to listen to the interview today. What are your thoughts?
I think it's been just fascinating. I love like you, my eyes lit up with the low T3 as a nice little clinical sign. And so fascinating and about the way that the conversation finished, really, in terms of we see this life stage of perimenopause as definitely a time where women do highly restrict their carbohydrates. In the advent that they're not overweight, it is sort of, it's become a very, very popular diet model. And I think,
not always helpful though, but listen, I think we're going to have an amazing conversation in September. So if people are interested in what we've been talking about, don't worry, there's more to come. And we'll be involving Tanya more as well, hey? And also we'll really get into even more details and nitty-gritty and about navigating the whole female hormone odyssey in terms of our hormones, how they change. And so to give people tools and tips so they can, it's to a certain extent, make those important decisions. You know, knowledge is power, as I always say. And because we're all different, then everybody will pick up things and then they can go away, top tips, go and apply it for you, what's right for you.
Well, and the menstrual cycle is a barometer of health. It's such a
Mhm.
handy thing for women. I feel sorry for men. They don't have that nice kind of monthly feedback about, okay, how am I doing? How am I doing?
Totally.
So we'll look at that in September. I'm so looking forward to seeing you in person. It's just
Likewise.
what a treat to be able to have an in-person event. And just for everyone listening, we've decided to not record that event. Actually, I believe. I mean, maybe we'll
Yeah.
decide
No, we're
close
gonna.
to the
We want
time, but
it to be, yeah.
it's in person. So if you are anywhere in the UK, please try to come join us. And thank you both. Thank you, Nikki, for sharing all your wisdom. I'm sure that's yeah, it's been very helpful for everyone, and I'm looking forward to learning more from you in September.
Yeah, thanks so much for asking such interesting questions, and Tanya, thanks so much for helping organize us. And
You're welcome.
and do come in September is the thing, and it's at Oxford University, so actually it's pretty easy wherever you live in the UK, you know, to get there, and I believe it's not a big walk from the station. So yeah, please come.
It'll be a Sunday afternoon.
Yes,
just
it's
a
Sunday
nice
the 3rd.
little, September 3rd.
And
just
come with your
day.
questions. We'll be discussing, having this conversation, but then absolutely, this is why having these things live and in person is so important, because please come, bring your questions, or you might listen and then you'll have a new question. And so you can often learn stuff also from other people's questions as well. It's like, wow, that was an interesting question. I wonder what the answer is. So yeah, please, we encourage everyone to come. So it's a lively discussion, don't we?
And we
Absolutely.
thought something that we really wanted to get across was that this is an open discussion for you to bring your daughters or your nieces, because we are basically talking about the love of the menstrual cycle and that is really the center of the conversation. So we want to be able to share that knowledge and open up that whole discussion about that beautiful transition across those decades and educate our young women as well. So bring your daughters, bring your nieces.
Yes.
Yeah.
Good point. It'll be lots about younger women, lots about the onset of periods. We are going to talk about, I'm going to end up talking a bit about hormonal birth control and some of the
Brilliant. Yeah.
potentially problems with that, and maybe some alternatives to that. So today was mostly about women in our 40s, but September will be
the whole spectrum.
Mostly the whole spectrum.
The whole journey, the whole odyssey.
Yes, the whole journey.
Yeah.
So wonderful, you guys.
Brilliant.
Thanks again. And we'll see you hopefully in September, everyone. All right. Take care.